I'm Dr. Victoria, and this is George.
Today, we are going to talk about ADHD. George always had a hard time in school, and he had a hard time concentrating. He always got in trouble with his teachers because he could not stop moving and would make careless mistakes. At sports practices, the coach would yell at him because he could not pay attention. Even his grandmother thought he was poorly behaved because he would not listen when spoken to. Everyone says it is like he is being driven by a motor. George has something that he's never been treated for, but is finally driving even him crazy. George has ADHD, Attention Deficit Hyperactivity Disorder. Individuals with ADHD are impulsive, have poor attention, and may be hyperactive in 2 or more settings. This affects the cognitive, academic, behavioral, emotional, and social functioning. There are 3 kinds of ADHD: combined, inattentive, and hyperactive impulsive. In combined ADHD, the most common kind, there is decreased attention and focus with some hyperimpulsive features. In the inattentive type, there is decreased attention and no hyper or impulsive features. And in hyperactive impulsive type, there is less of a problem with attention, but lots of hyperactivity. This is what is most common in preschoolers. ADHD is more common in males than females. If a parent has ADHD, there is a 25% chance the child will have this. 9 to 15% of school-aged children have this condition, and symptoms start between the ages of 6 to 12 years of age. This makes it more challenging to make a diagnosis when someone is an adult. There is no definitive cause that we know of for ADHD, but there are several genetic and environmental factors that contribute. There are multiple genes that affect neurotransmitter production, and it is believed that low dopamine and norepinephrine lead to ADHD. Environmental contributions to developing ADHD include a low social economic status, having a parent with a mental health condition, being in foster care, having a low birth weight, or being a preemie, or having an acquired traumatic brain injury. Patients may present in preschool, elementary, or adolescent stages of life. More prominent symptoms are related to poor executive functions, including abstract reasoning, working memory, and response inhibition. To make the diagnosis of ADHD, there are several criteria to note. However, it is important to rule out other conditions with similar symptoms or coexisting conditions such as oppositional defiant disorder, conduct disorder, depression, anxiety, a learning disability, a developmental coordination disorder, autism spectrum disorder, or sleep disorder. Depending on the age of the patient, the number of symptoms varies. For patients 16 years of age or younger, they must have 6 or more symptoms in inattention and 6 or more symptoms in the hyperactivity impulsive category. Patients over the age of 16 require a minimum of 5 of each kind of symptom. All of the symptoms must be present for at least 6 months and be inappropriate for the patient's developmental level. This takes into consideration the patient's age. A 6-year-old will behave differently from a 13-year-old. Symptoms of inattention include not paying attention to details, careless mistakes in schoolwork or within a career or other activities, trouble holding attention on tasks or play, and not listening when spoken to directly, not following through on instructions, or failing to finish schoolwork, chores, or duties in any setting, including a workplace. Hyperactivity impulsive symptoms include fidgeting, tapping of hands or feet, squirming in one seat, leaving one seat when they should remain seated. A younger child may run and climb where it is not appropriate, while an older child may merely feel restless. They may be unable to play or take part in leisure activities quietly, may talk excessively, blurt out answers before a question has been completed, and others may remark that they are driven by a motor. All of these symptoms must occur in more than one setting. Parents can evaluate how the child behaves at home for one setting, and we often get behavioral forms filled out by school teachers to evaluate other settings. Treatment for ADHD includes behavioral modifications and medications. In a child, it is important to develop time management and organizational skills. Having structured routines is very helpful, and in a child 4 to 5 years of age, it is best to start with behavioral changes rather than medications. Behavior and environmental changes include having a strict schedule, decreasing distractions, having logical places for school items, toys, clothes, setting reasonable small goals to achieve, rewarding positive behavior, identifying unintentional rewarding of poor behavior, using charts and checklists, limiting the choices available in decision making, finding an activity or hobby or sport where the patient can find success, and using disciplines such as timeouts, distracting, or removing the child from the situation. In adults, it is important to decrease distractions and develop their organizational skills. Like any other child with or without ADHD, it is important to encourage an hour of physical activity each day and be diligent in limiting their amount of electronic use. This includes phones, tablets, TV, and computers. Our first line of treatment includes stimulants. These help to increase the amount of neurotransmitters, in particular dopamine. Stimulants are controlled substances, and when prescribed, we have to be cautious. An illicit stimulant like methamphetamine acts very quickly and has great potential for being addictive. We try to prescribe more slow-acting stimulants to have a slow release of dopamine so that a patient may have better control and increased focus and attention. Stimulants include dextroamphetamine and methylphenidate. They can come in various formulas so that the time a patient is being treated may vary from a few hours to a full school day. In general, we try and pick more long-acting formulas so that the risk of abuse is lower. For example, we may prescribe a long-acting stimulant that would last 8 hours. However, if a patient finds that they are having difficulty finishing their homework at the end of the day, we may prescribe a short-acting medication as well so that the patient can focus and complete their work. The art of medicine really comes into play when treating ADHD, and several medications may need to be tried before the right fit is found for a particular patient. As well, perhaps a stimulant is not the best choice. A common alternative to stimulants includes atomoxetine, a selective norepinephrine reuptake inhibitor. Side effects and risks of stimulant use include decreased appetite, which can lead to poor growth or weight loss, sleep disturbance, jitteriness, emotional lability, and social withdrawal. It is important that the patient take the medication on an empty stomach to avoid stomach upset and then eat breakfast right after so they can have appropriate weight gain. As well, it is important to check blood pressure and heart rate as there can be cardiac side effects. Contraindications include asymptomatic cardiovascular disease, moderate to severe hypertension, hypothyroidism, anxiety, concurrent monoamine inhibitor use within the past 14 days, and a history of drug abuse. The short-acting stimulants may cause an euphoric response, so someone may take a higher dose than is prescribed, or someone may try and take the medication when it was not prescribed to them personally by a physician. If the patient is having significant side effects, it is important to evaluate whether this is occurring during the hours of treatment or after. If significant side effects during the hours of treatment, especially concerning mood side effects, that may be an indication to stop treatment. If the side effects are occurring after the hours of treatment, this would suggest that the patient is having withdrawal from the medication. While it may sound counterintuitive, this is actually an indication to increase the dose of medication, and it is safe to do so. Comprehensive treatment includes support for the family, providing online resources, encouraging communication between the parent and teacher, for example, daily or weekly communications about attainable goals, whether it is completing assignments, having success with a particular rule like not talking back at school, or building better relationships between parents, teachers, siblings, or peers. If there are any coexisting conditions affecting learning or mood, they should be addressed, and any sleep concerns should be evaluated and treated. Follow-up for these patients should start with weekly visits during the titration phase, and depending on adherence, visits every 6 months may be possible. As well, coexisting conditions and persistence of symptoms can be addressed during these visits. Any poor response to medication should include evaluation of coexisting conditions or psychosocial stressors, non-adherence, or an incomplete diagnosis. Some providers encourage medication-free weekends or summers. This can be evaluated on a case-by-case basis. For some patients, being off the medication causes them significant distress and they have difficulty participating in activities of daily living and group sports. So daily treatment would be better for them. For George, we need to do some screening and robust history taking since he is out of school and a bit older to be making a diagnosis of ADHD. In fact, we can send him to psychiatry to confirm our diagnosis of ADHD. It will likely be reasonable to start George on a long-acting stimulant to see how he does and see if we can help him focus in his entrepreneurial business plans. He was sharing plans with me how he would like to rescue kittens from parking lots. To rescue kittens, George is going to need to develop his organizational skills, decrease distractions, and take advantage of using charts and checklists. Thank you for joining me today, my healthcare team. We have some brilliant minds that we get to help so that they can flourish, focus, and stay organized to be successful in and out of the classroom. Bye-bye!